typical of Shiv's personality of trying to figure out why things work. We have had a very minimalistic view towards catheter ablation for even persistent atrial fibrillation. Have kind of stood by it, and it's often difficult to offer apologies for this. So imagine this scenario that happens over and over again. Someone in an outside hospital does an AF ablation and it fails, and they refer their patient for repeat procedures. And they say things like, well, I did pulmonary vein isolation and it didn't work, so what are you going to do to enhance what I did? And I stammer a little bit and tell them we're going to do pulmonary vein isolation and try to induce non-pulmonary vein triggers. And they say, that's all? I could do that. Well, apparently they couldn't. So I wanted to dissect just a little bit of the psychology of how we got here. And I certainly don't mean to cast aspersions on anyone's work at all, and most particularly Andreas, whose our viewpoints couldn't be more different, as it turns out. I think what's important is what you are capable of in your lab. It's unfortunate right now. That's the best that we have to go on. This works for us. It wouldn't necessarily work for other people. What Andrea does works spectacularly for him. It wouldn't necessarily work for other people. I don't know what that means. It's possible that there's a difference in what people are able to do. It's possible that there's some other differences that we're not picking up on yet. But I also, like Shiv, wanted to point out the fact that meta-analyses of these disparate experiences are not likely to lead us the way home. And this is a perfectly good meta-analysis of ablation of long-lasting persistent atrial fibrillation done by an Australian group. And it kind of gives the impression, when I look at these graphs, so this is less aggressive ablation to most aggressive ablation. And it seems like if you look at any of the metrics for success, it's going up as you get more and more and more aggressive. There's also a publication bias in this. You can look at old studies on the left and newer studies on the right. Of course, you're not going to publish a study unless it works out better than the previous. Their conclusion in all this was, like most people have, there's a lot of variation in success, a lot of different techniques. But like most people, they concluded that persistent, and particularly long-lasting persistent atrial fibrillation, there needs to be more substrate ablation than just ablating the PVI. Yep. So I think the original iteration of this idea comes from this study. And again, I'm not trying to poke fun at anybody. The Michigan investigators have contributed a great deal of very valuable information to this group. But in a total of 70 patients, they did segmental PVI in mostly paroxysmal patients and a couple persistent patients, demonstrated pretty good success in the paroxysmal patients and really terrible success in the persistent patients. And that's what led to this idea that more had to be done. This study has none of the earmarks of what the HRS consensus guidelines have said for results. All of the recurrence happened within what we would now call the blanking period. And then they have these lines that exist in parallel space out to infinity, which to me means that those patients weren't monitored anymore. This is the most difficult thing about AF studies. No one wants to be monitored, particularly if they're feeling well, and all of our monitoring applications are pretty noisome to patients who want to forget about atrial fibrillation and don't want to contribute to our science projects. So I don't think this really carries the day. We looked at it in our lab, and this is not a high-quality study, but it's one that we did. And I think it points the way to other things that kind of inform the way that we think. This was the Rasta study. It was a randomized comparison in persistent atrial fibrillation patients of 3 different strategies. One was PVI plus ablation of non-PV triggers that were demonstrated to induce atrial fibrillation. That was arm 1. One was PVI plus empiric ablation of sites that we expected non-pulmonary vein triggers to anatomically come from. And third was PVI plus not extensive cafe ablation, but some cafe ablation in left atrium. And what we found was This is PVI. This is PVI plus empiric anatomic ablation. This is PVI plus CAFE. What we interpreted this to mean is that when we try to do more extensive ablation, we had less good results, and we couldn't figure out the reason why. It made me think that we spent less time, less effort, less deterministic, just, all-out effort in trying to do the PVI part of it, which may be the most important part. We also said that alongside of what Shiv said, not being sure of the mechanism, if we don't know what the mechanism is, we'd like to stick with what we're familiar with and what we understand, that many of these things come from the pulmonary vein. We understand that because we do all of our ablations in sinus rhythm if we possibly can. So when we have someone with persistent atrial fibrillation, we cardiovert them. If they have recurrent atrial fibrillation during the procedure, it's triggered from the pulmonary veins, just like paroxysmal atrial fibrillation is. So we felt comfortable with that mechanism, even though that's not all of it. And there are probably different kinds of atrial fibrillation, as Shiv was noting. So more so about the specific parts of other ablation procedures. Linear lesions are very difficult to do. We're seeing that currently. And lesion gaps are proarrhythmic. There's an increased incidence of non-AF rhythms, which are more difficult for patients to endure with substrate ablation. Something that we've largely forgot, that extensive ablation may result in reduction in atrial function. And then there's this thing that we keep forgetting about asymptomatic particulate matter going to the brain during ablation procedures. And it seems to be that if the ablation procedure is causing that particulate matter, then more ablation would mean more particulate matter. So this is ablation light, if you will, but we stand by it because we feel like it's rooted in what we understand. This is a really nice study that I missed first time around. This is a Bordeaux take on atrial function after stepwise ablation. And there seems to be, in their initial thoughts about this, where you can't tell whether the fibrosis comes from the disease process or the ablation. And this analysis kind of nailed it down with pre and post MRIs to the ablation. And the more ablation you do, the less well the left atrium behaves afterwards. So we think that our RASTA study, in a very small way, kind of presaged what is a much better study in the STAR-AF2. That in looking at the difference between pulmonary vein isolation plus CAFE ablation, isolation plus linear lesions, they were indistinguishable except in the amount of time that it took to do pulmonary vein isolation. So that took the least amount of time, the least amount of ablation, and did just as well, if not a little bit better, but not really all that well. So this is the best possible way that the data could be parsed. This was atrial fibrillation by itself, not all atrial arrhythmias, on or off antiarrhythmic drugs. So this is kind of the picture from the New England Journal article. But if you look at kind of a traditional look at this, 12-month freedom of all atrial arrhythmias off antiarrhythmic drugs, all of these outcomes are pretty poor. So bragging rights belong to no one, except that we were kind of at least judged through this lens, maybe a little justified in thinking against extensive ablation. So this is based on our current understanding. This is what we do. We do antral PVI, ablation of non-pulmonary vein triggers for atrial fibrillation, with a lot of time spent on trying to induce these triggers with high doses of isoproterenol. We think that that's what is needed in most people that would benefit from atrial fibrillation ablation and persistent atrial fibrillation. Now, let me explain that a little bit. I'm almost done. It wouldn't take care of the entire universe of atrial fibrillation, but the entire universe of atrial fibrillation doesn't need taken care of with ablation. If you have persistent atrial fibrillation for 25 years, nothing's going to work, and that's probably an entirely different mechanism than the sorts of patients that we're approaching. We do persistent and long-lasting persistent atrial fibrillation in appropriately symptomatic patients that prove themselves to be symptomatic with tested cardioversion. So if this hypothesis is correct, we've poured more and more of our industry into not making different lesion sets, but making sure we could get better at durable PVI. Our results are not that great. They're honest. Single procedure off antiarrhythmic drug success for this procedure is about 38%, very much like what the study that it showed was. We see very low non-AF recurrence. There's no atrial tachycardias or atrial flutters. And there's not a lot of need for repeat ablation. And what I think what this means, so we had 28% in this study of 220 patients. And sometimes what happens is there's a window of patients with persistent atrial fibrillation. They're symptomatic when they enter the beginning of this process. They have an ablation, and then they lose that window. It's no longer so important to them symptomatically to be free of atrial fibrillation. But like everything else, repeat ablation, addition of antiarrhythmic drugs can control symptoms in those who still have it. So what that looks like for us is about 70% of patients, 78% of patients are improved by 2 ablations with or without the addition of antiarrhythmic drugs in a few, and with occasional breakthrough AFib recurrences in a small number of patients. As a reality check, that's kind of what multiple procedures did in the thermocool paroxysmal atrial fibrillation ablation sort of realm. So maybe that's all we're really capable of. It sounds horrible. It's really hard to talk about in places like this or to referring physicians, but that's certainly what we can manage. So trying to make PVI better. We think this is part of it. So Louise showed something like this before. We're really big fans of this jet ventilation. If you take the movement of the diaphragms out of the way, the catheters don't lurch in space. We have a halfway decent chance of keeping them where we're trying to ablate. We did a study looking at this in 3 sequential groups. And sequential groups are a bad way to collect data, and a lot of the mistakes that we've made in this field so far are based on sequential data. But sequential groups of 100 patients in which each group got a little sicker, so it's a little bit more justifiable. We looked at the incorporation of image integration, steerable sheaths, and jet ventilation. In the third group, we had all 3 of those. The second group, we had 2. The first group, we had 1. What we saw was meaningful improvements in 1-year survival from recurrent atrial fibrillation with each of this increment in adding technology to the fore. This is modern now in a mix of patients, about 50-50 with persistent and paroxysmal atrial fibrillation, off antiarrhythmic drugs having a 74% success rate. We think that's real. We think that's the best we can do. Real-time force measurement, we spent the whole morning talking about. We think that's an important addition on top of the results that I showed you from that study. So our apology for this. The fact that there are more than one way to do atrial fibrillation ablation means that we're not sure where we're going yet, just as Shiv said. AF is a complex, multifaceted disease that lasts a lifetime. I think we don't have enough adjectives to describe it right now. I think that there are pulmonary vein-triggered atrial fibrillation, there's substrate-triggered atrial fibrillation, and probably hundreds of things in between. We need to understand how to describe those better so we know what sort of procedure to do on what patient. We believe that the majority of patients with persistent atrial fibrillation would be appropriately treated with permanent pulmonary vein isolation. It's just that that's difficult to do. Thank you for your attention.